And then first steps I do is basically address the outflow tract. In the model that we have here, it appears to be very small. I'm generally always looking at the valve first and see, because it, in my opinion, rarely correlates exactly with the echo. And the valves that appear very small on ultrasound, they may not actually be as small as you expect them to be when you open up the main PA. So first thing I do is placing my stay sutures to the pulmonary artery. These are half thickness bites and roughly one on each side. Oops, they're pulling through. I have to do full thickness here. Okay. So they are basically just to give you better exposure to your pulmonary valve in the RV outflow tract. So in this case, I'm expecting that I'm going to have to do a transannular patch, but I'm still approaching it just the same way that I would if I was planning on doing a valve sparing TOF repair. And so I place two on each side and one basically at the level of the valve annulus. So going transannular here is full thickness here as well. And then I'll take an 11 blade and open that up longitudinally. And with your stay sutures being in place, you kind of get a good traction. Your assistant can lift up the PA quite well, and you can make an incision there. And I think to set yourself up as easy as possible, you have to make a proper incision in there. If you're just kind of nicking the artery, then usually there is quite some backflow coming out of the PAs, and that makes it difficult for you to actually find your incision again and widen it up with your scissors. So usually main PA aligns quite fairly well with the LPA, so you can look inside, but I usually extend it distally first, and depending on the size of the vessel, you can extend it into the LPA. If you have very small pulmonary arteries, then you can, based on what you plan to basically enlarge with a patch, you can extend it into your LPA. You can get a decent look at your RPA and probe them. But most of the time, I would say, you get away with basically a limited incision into your LPA, and then you take your spring scissors and basically gradually cut towards your valve. And I mean, the key is to really make yourself aware of where your valve sits and how your commissural posts are, and see basically that you're not cutting into your valve if you're planning on doing valve sparing repair. And without having seen the valve yet, it's worthwhile basically using that time and assess it. Many of them have bicuspid valves, so does this one. At least looks like it, not really perforated. I'm just discussing a bit of like valve sparing aspects that may not apply to this model, but sometimes you have your commissural post sitting quite anterior, so you can deviate your incision into the sinus, and at times it really helps if the vessel itself is small, but the valve doesn't appear to be crazy hypoplastic, to extend your incisions into both sinuses, so you can actually get down to the valve level and get the maximum enlargement out of it. I think here the valve looks fairly small, but we would usually try to widen the valve up. Usually you see some fusion of the valve leaflets of the cusps, and you can split those with a 15 blade, for example. You can take down commissural posts to get even more out of your valve annulus. But I mean, in this case, and for the reason of keeping the procedure relatively short, I would just cut across the annulus here. What you have to watch out for when you do that, and that's something that you basically automatically look at before you start working on your PAs, is if there are any prominent coronary branches that cross over. Some can really cross over right at basically the level of your annulus, and that limits what you can do. In worst case, you can just open up across there, and you may end up having to place a conduit in that basically gives you a double outflow of your RV to your main PA. Also important when you cut into your RV outflow tract that you basically align your incision with the outflow tract. So it's easy to either go too far back or basically go across towards your LV, and then you're risking other coronary arteries and you're not well aligned. So I'm just cutting across there, usually giving up on your suture here. And what I usually do is I limit the amount of or the extent of that infundibular incision, because all you want is basically you want to get rid of the obstruction. You do transannular patches usually if your valve annulus is too small. If it's just the infundibulum, you could get away with an isolated infundibular patch and leave the valve as it is. So you're basically extending it into your infundibulum and look if you are opening up adequately. I would then, I usually don't make the infundibular incision before I've actually looked at muscle bundles through the RV, and that's so you usually switch back to your atrium and have your assistant, usually have to use both, basically just lift up the tricuspid valve towards the outflow tract, and that with usually a sucker, so you can basically get quite decent exposure of your outflow tract there. And the idea is to look into your outflow tract and identify any muscle bundles that are obstructing your view, and that may be quite tricky to see on the camera here, just because it's a very the exposure is limited to basically me looking into the outflow tract, but what you see is basically you see your VSD with your aortic valve sitting there right next to it, and then you see a strong muscle bar, and I think the key importance when you assess it is the distance that you keep from your aortic valve while you're resecting these muscle bars here. So I don't know if that's been clear based on my explanations. I would usually work on the valve first, but not cut across the valve, and assess the RV muscle bundles. And I usually want to be confident that I've basically resected anything out of my infundibulum, out of my RV outflow tract, that I can resect before I make the judgment call for or against the transannular patch. In this model, I just know that the valve is too small and we can't do all the functional testing that we usually do. And as Glenn pointed out, as you start cutting, you want to basically see your pulmonary valve from within your within the RV. And that's barely possible at the beginning. And as you start resecting muscle bundles, you get deeper and deeper into your RV outflow tract, and at some point you start seeing the valve cusps from the inside. So I don't know if they can really see inside of this. Is it okay? Yeah. So I can probably point out where the aortic valve is. So the aortic valve sits around here, and this muscle bar up here that crosses over the free wall basically of the infundibulum, that can be resected. Just don't know how big the model is here. But you basically make a deep incision into that muscle bar here and grab it with your forceps. And then you start basically cutting it out of the RVOT. And one thing that takes a while to understand, so at least took me a while to understand, is to get an idea of how deep you can cut. And usually if you speak to surgeons, they refer to a layer that you got to be in. And you'll see that in the operating room once you get more experience, that there is usually underneath these obstructive muscle bundles basically a well endocardialized shiny muscle layer that you want to basically be in when you resect your muscles. And that's quite a good indicator that you've resected enough muscle. Sometimes it helps if you can't see the muscle adequately to have an assistant push on the outside and basically get your RVOT into your view. I can't really grab it there. So that's the muscle bar. And then you can cut this out. And then you get big chunks of muscle out of your RVOT. And you do that basically up till you can visualize and see your your pulmonary valve. This is basically at the free wall of your RV outflow tract, but there are usually a lot of muscle bundles that extend basically from the septum to the free wall. And you orient yourself on the moderator band. Basically, that's quite prominent sitting up down here. And what we usually take is a mixture or some 90-degree instrument that you can basically go underneath and pass it through to identify them as true muscle bundles. And then you kind of try to get as much out of these muscle bundles as well to further give your RVOT a stronger, like a wider opening. And if you're looking at basically that layer that you start seeing as you resect muscle, that's telling you quite well how deep you can go. If you're too aggressive resecting, then you're at risk of either perforating to the outside, and worst case scenario is that you're actually hitting a coronary artery. So you have to be quite attentive of how deep you can go, how much you can resect. And at times, to me, it's quite, when you're quite confident that you've resected a lot, getting a probe through your RVOT and basically feeling the probe from the outside basically gives you a quite nice feedback of how thick your remaining muscle is as well. But you're basically pushing it towards your pulmonary valve. If you can cross it already, you can also use it to size it. But you're sure you're in the RVOT, and then you can feel the probe against it. And many times, if you've left something in there, you can feel like a strong bar sitting there still, and you can go for that and resect it quite nicely. That's quite good feedback. It's probably, if you have the chance, worth doing that before you start resecting, just to get an idea of what it feels like in the beginning. I rarely do that, but it's just another feedback that you can have. Then you can size your RVOT Usually, I think most of the TATs, they need a pulmonary valve about 10 millimeters in size. Can switch that back again. But to me, it's also like if I have a 9 millimeter valve and I'm otherwise quite confident that I've got rid of every obstruction underneath the valve, I may actually try closing the VSD, patching the PA, and coming off pump and see if my hemodynamics are reassuring. And at times you have decent RV systolic pressures and relatively acceptable residual RV outflow tract obstruction that may allow you to keep the valve. Again, in this model, I think the valve's just generally pretty small. So what I've done here is I've already extended it into the RVOT. But when you do that, and even with the valve intact, it allows you to also look into your RVOT from up top and identify any muscle bars that sit right underneath the valves. And sometimes it's worth chasing those with a fine blade and cutting them out on additionally. If you have the incision like this, you can also resect muscle from there quite easily. Once I'm content with how much muscle I've resected, then I address the VSD. And again, you set yourself up basically when you resect the muscle, how well your VSD closure is going to be. Because if you've resected too aggressively, too close to the aortic valve, then you have barely anything to suture your VSD patch to. That muscle is pretty thin. You need endocardial layer. You can't really stitch to muscle itself. That won't give you the strength that you need to securely anchor your patch. And then I size the VSD depending on the override that you see from the aortic valve. You have to count into a bit of bulging of your patch. So if you have a lot of aortic override, the more you have to create rather a tunnel than just an additional plane. So you usually have to widen your patch a bit and also lengthen it a bit. And I measure that with the forceps usually. These models, it's sometimes a bit trickier than in real life to differentiate between valve and muscle, just because the color is pretty much the same. And then I roughly size that. Cut my VSD patch. Usually intentionally oversizing the patch a bit. It's always worse to have a patch too small, and kind of tries to trick you into working with the patch that's too small, and you're not going to end up with a nice VSD patch in the end. So yeah, I usually leave that edge rather long. Most of the time end up resecting more to that once I'm further advanced with the patch implantation. And then I would usually use a 5/0. So I start pretty much at the deepest point of the VSD, probably a little bit towards the outflow. And then we'll go chasing the VSD. You sometimes can put your forceps bit into the VSD and push it, so you get better exposure. So probably another lecture here is you have to take fairly deep bites, and in these areas, once you're past basically the deepest point of your VSD, you're very unlikely to hit any conduction tissue, so you can be fairly generous in terms of what you. So conduction is more important towards your inlet. You have to be more careful of how deep your bites go and to orient myself. Okay, that's all right. about 3 bites, and then you go down. And this is kind of the area where I'm stitching now that is totally dependent on the amount of muscle you've left when you resected your RV outflow tract muscle. So if you've been too aggressive, all you've left, or worst scenarios, tore again through the patch. Pull it up. And the worst scenario is that you're almost hitting your aortic valve. And another helpful move in this way, sometimes like the outflow, or like the margin towards the outflow of your VSD is tricky to identify and to see, but you can use your patch as kind of a means to retract things and to get it into your view, and then you can basically pull on your patch while you're putting the needle in, and get it.
So as you're coming around leftward here, you'll see the aortic valve, and it's really important that you stitch. People don't follow that rule. See the aortic valve, make sure it's smooth muscle between the aortic valve and where your stitch is, and you won't have a residual VSD there.
So I struggle a bit here just because everything's the same color. And with regard to residual VSDs, it's also many times have the impression you have to really be clear how close you go up to the tricuspid valve annulus. There's usually still some kind of length to the VSD edge, and you have to really make sure that you're exposing it adequately, that you're not basically just want to get it done and you're thinking you're close enough to the annulus. You have to really see where the upper end of your margin of the VSD is. And
so this is where I like to talk about intellectual honesty, meaning see your last stitch, don't guess where your last stitch was, see where your next stitch is going to go, don't guess where it should go. That way you're not going to leave residual VSDs, and what Christoph is alluding to is if you don't see the last stitch and flatten the tissue, you may actually leave a crimp, which can be a residual VSD. So always be intellectually honest about flat tissue, no trabeculation, seeing your last stitch, and going adjacent to your last stitch, whatever your decision is on 1 millimeter, 2 millimeter advance, so that you don't leave residual VSDs. And you can see it coming out of the operating room, looking at that echo, who paid attention and who didn't. There are no lies anymore with post-op echoes if you're doing post-op echoes.
okay. So you can see, I don't know if that's on the camera, but you really see basically a rim of muscle around the aortic valve coming towards your tricuspid valve annulus. You can sometimes, if you want more exposure, put a stay suture underneath your tricuspid valve leaflet to retract it even further, so your assistant doesn't have to. You can put sutures around your cords to retract them. Just try to get comfortable with basically the exposure. And as Glenn said, it's really important to be honest to yourself, and like if you can't see it properly, don't put a stitch in. Make sure you're confident of what you're suturing there, and rather take your time, and in the end it's going to probably save you time if you get it right the first time instead of ending up having an important residual VSD and then have to go back on pump. It's always trickier to fix if the patch is already in place, and the exposure is likely going to be worse. Okay.
It's a little stiff, so it might tear on you.
So another important thing though is that with restriction anteriorly, you have to watch the assistant and make sure that there is not too much tension on the tricuspid valve. So you can, especially if the kids are not around 6 months but younger, tear cords there if you're kind of pulling too aggressively. Then you end up having to fix the valve for a relatively simple procedure. This is more now the part where you have to worry about conduction, so you should basically try to get further out with your stitch. I don't know if that can be seen very well. So you kind of start further off the rim and leave before the actual VSD rim starts. Make sure that you're away from conduction. So I can actually just trim the patch. So again, that's more important if you have a lot of override to see that you're actually leaving some kind of a tunnel there. But if we kind of end up here, then yes, I've cut the stitch there. So I'm not going to fix that separately for the sake of the presentation. So, and we are basically never taking down the tricuspid valve leaflet. I know that's basically done in other departments quite regularly. To me, what I always try when, or what for me is a good indicator if you get it right when you don't take down the leaflet, is if you have to do a lot of tricuspid valve repair once your patch is in, because that's kind of telling you if you've tethered the valve a lot or not. I always try to, or I always want to basically test my valve and see that the valve's just working as well as it did before, because otherwise it's kind of you tethering the tricuspid valve cords as you've basically passed it underneath or have some residual patch pushing on them. So I usually go back and forth between the cords here. Wait. just part of the model cord. So that I'm underneath the cords. Sometimes the stay suture underneath the cords can pull it quite nicely out of your way. And then that also allows me to stay relatively far away from the edge, so I can safely put it in remotely. And then basically cut it out again, weave it underneath the cords here, like this. And then you get your patch again. And the same back again. So at times may appear to be a bit tedious, but still a quite nice way to basically spare the valve. I mean, this cord here is not attached to the valve properly, so I can't really avoid it being tethered. And same here. Sometimes your exposure underneath these cords can be tricky. You should take your time and make sure that you're not leaving a residual VSD just at the top end of the inlet part. And again, it's usually quite a stretch to go, so almost always a bit longer than you would. So you see the valve cords are tearing here in the model a bit, but still quite nice to have these cores. We used to have models without the valve in there, which kind of made it quite a bit easier to close your VSDs. And I've basically copied that from Osami. Like when I feel like I'm very close to the annulus, then I leave the suture like it is now and add a second suture that is pledgeted, that I run. Not sure if I do that in this model, but basically add a pledgeted suture here with one end going in just like the regular VSD suture, and the other end going through the annulus, and a second pledget on the same suture guiding the suture back through the annulus or the base of the leaflet.
You go through the annulus or the leaflet?
No, the base of the leaflet. That's what I've just corrected myself. And then back through the patch, and that kind of pulls the topmost end of the inlet part of the VSD, and the tricuspid valve basically close together and very nicely avoids any minor residual leaks in the area. I mean, you don't have to do that. That's just basically what I've been trained with, and that I found quite helpful to avoid any residual leaks. And then, do we do the full pledgeted sutures to the annulus? So usually this part of the tricuspid valve is then closed with pledgeted sutures. So you're basically putting in mattress sutures through your top part of the VSD, through the base of the leaflet into a strip of pericardium, and you will have probably in this model 3 or 4 that then wedge it nicely to the tricuspid valve and close off the VSD. If you take down the leaflet, I've seen a lot of basically running sutures, people that basically take the free margin of the leaflet, stitch through that, through the remnant of the basically part that's still stuck at the annulus, and a strip of pericardium, and run it over and over and over. And then it's basically tightened with a nerve hook to make sure that it's all sitting down nicely. But once you're done with your VSD, then you de-air your left heart. You can take the cross clamp off and do the main PA reconstruction while your heart's reperfusing. Pretty nice to use the time, have it re-warm and nicely reperfused until you're done patching this. You're pretty much ready to come off pump. Usually, depending on if it's transannular or not, I use autologous pericardium or treated pericardium if I was confident that I'm going to end up using a transannular patch anyways. But I would say
so if you're going to do a transannular patch and use autologous pericardium, I would suggest make sure you treat it with glutaraldehyde.
Yeah.
Because when people didn't, many years ago, you get these aneurysms of the artery outflow. If you're supraannular and would preserve the valve, it doesn't matter. But if you're crossing the annulus, you're going to want to treat it with glutaraldehyde.
I mean, in those probably needs a bit of explanation that we at times try to spare the valve annulus and base our decision on post-repair hemodynamics, basically measuring RVSP and gradient across the valve. And if we then get more than 2/3 systemic RV pressures, for example, and important residual gradients, then you may basically switch from a valve sparing to transannular patch or an isolated infundibular patch, depending on where your obstruction is. But then many times you already have autologous pericardium in your main pulmonary artery. And for the basically ease of getting your procedure done, we've used AccuSeal patches for basically the part of the patch that sits on the RV outflow tract and basically across the valve. You could still use treated pericardium, but it means you have to wait for it to be treated, etc. It's nothing particularly special about the AccuSeal that makes it more suitable. It's just the material that's readily available when you're at that stage of your procedure. Then I usually place it upside down up here. One thing that you kind of have to manage while you're running the suture is backflow from the PAs. So you want to have properly drained your right atrium because you'll have coronary blood flow returning to that, and either have suckers in there or you snare your branch PAs. Most of the time I would just have suckers in there. It's usually good enough exposure to have you go there. So don't take the depth of my bites for granted. I'm just afraid that it basically tears through the model. And important is you want to enlarge your pulmonary artery. So you want to take small steps on the side of your PA, large steps on your patch itself.
So while Christoph is sewing us in, I wanted to take a chance to get you to think a little bit about tetralogy. So if you look at the STS database and then the European database and then the update that was presented at the World Congress, the vast majority of TET, something like 80%, have kind of an old-fashioned repair. And it turns out there's a lot of emerging data in the literature that if you do a more preservative type repair, so less muscle cutting, more annulus preservation with or without some functionality to the valve, that number one, it can be done. Number two is if you start looking at long-term data, the RV is healthier. It's a lot harder surgery because you have to take time to discover whether or not you can do that on that particular patient, whether they tolerate it or not. And you might be wrong, you have to go back on bypass and add a transannular patch or another type of modification patch. But it's starting to look pretty seriously like it's to the benefit of the patient. So I would submit to you that speed is not the most important thing in these patients. The most important thing is to try to figure out how you get a ventricle that's healthy 20 years from now without having had to put a pulmonary valve. And if you do the old-fashioned transannular patch transventricular repair, we know they're going to need valves within 5 to 15 years at a high percentage of the time. And we know now with MRI data that if you do a valve sparing technique, which you could probably do about 80% of tests, 70 to 80% of tests, that 10 to 15 years, their MRI data is, in terms of volumetrics, is much better. There's a little bit of cost, and that's the upfront operating time that's increased. And then there's about a 5% that come back for early reoperation for stenosis. But by 15 years, the operative rate is completely different, i.e. being much higher than those who had the more traditional repair. So food for thought for you guys to think about that are already in practice or that are getting ready to start your practices. How to benefit your patients in the long term.
Yeah, I think it exemplifies a common theme in congenital heart surgery that you may get away with a result quite well in the short term, and you don't get that direct feedback of which one is better. If you put a transannular patch in, you're pretty sure you've gotten rid of all the obstruction there is, and they may do quite well initially, but like that's not the whole goal of the procedure. You want them to be doing well and needing less reintervention in the long run.
And then just in terms of general philosophy, I think, when I came out 20 some years ago, there was still a sense that speed was really important. And I'm not saying, efficiency isn't important, but so I think probably everybody would say if you could do a really fast if you could do a 2-minute Norwood, it's got to be better than a longer Norwood, but nobody can do a 2-minute Norwood. So within the ranges of what we do, the operations, your residual lesions are extremely important. The other thing I'd say is there's no magic in anybody's hands. It's all about, strategy and what residual lesions you're producing and decision making.
So once you're halfway down your pulmonary artery, a good thing to judge the length of your patch is by taking out your suckers and pull your patch down, like not with a lot of tension. Let it basically fill up based on the flow that comes back from your PAs and the antegrade flow from your RV. And then you see it bulging quite nicely and pretty much sits the way your main PA is going to look like at the end. And I usually then judge the length of it and just cut across, roughly like that. And then you can shape the distal end of the patch so that you end up having pretty much that round enlargement of your pulmonary artery. You have to be aware that your patch is redundant, so you have to keep, especially at the beginning and at the end, tailoring it to the actual incision. So you want to be redundant on your patch end and rather short-stepped on the myocardial side. And you'll see that with the models that they just tend to retain the shape that they have. Usually in real life, the RVOT stays open much nicer than you can see it here. Taking relatively big steps now just to speed up the repair. Lift this up a bit. Okay. That's it. Depending on your confidence of residual RV outflow tract obstruction, you can think of either leaving your AST shut if you've completely closed it, or what I would do in cases where I'm concerned of restrictive physiology, I would place an adjustable AST. Not sure if everyone's familiar with the concept, but you're basically placing a U-stitch like a mattress across your AST. So you go in bottom end of your AST, come out just on top of it. And then with the second step, you're channeling it out through the roof of the right atrium. You can usually see the sinus node artery, so be aware that you're not hitting it, you're distant to it. And that's done with the other end of the suture as well. You can put a tourniquet on the both ends, so you can control while your heart is closed if you open up your AST or not. Usually about 3 millimeters in size. Allows you to close it and de-air it properly while you're doing the reconstruction, and then on pump, once off pump and once you're assessing your hemodynamics, you can open it up. You can see if there is left to right shunting. You can leave it open if it's kind of acting as a pop-out valve and basically smoothen out the post-operative course to some extent, especially if you think there is a dynamic obstruction that's likely regress. Going to regress with basically remodeling of the heart. Okay,
Great.
that's pretty much it.
Thank you.